Hello, this is Robert Parisian. I'm an orthopedic sports medicine surgeon and associate professor at the Icahn School of Medicine at Mount Sinai Health in New York City. I specialize in sports medicine and minimally invasive arthroscopic surgery of the shoulder, hip, and knee, as well as cartilage restoration and regeneration for cartilage transplantation of all those joints when you have a major cartilage defect. The point of this discussion today in this talk is a talk that I gave on the proximal biceps and the management of this and modern surgical techniques at the recent AO North America Sports Medicine course called The Joint is an Organ. We're going to be discussing the management of proximal biceps as well as surgical techniques to utilize when you have a slap tear, a superior glenoid labrum tear, as well as some considerations with large rotator cuff tears. These are my disclosures. I'm a member of our various societies and committees within those national societies, as well as a consultant for a few of our industry companies who support us. I also am an associate editor and editorial board member for some of our journals with regards to research and evaluating research. All right, so the anatomy and biomechanics of the proximal biceps. It has a variable origin on the superior labrum or the supraglenoid tubercle, we call it. It forms weak links that predispose to slap tears. These are tears of the superior aspect of the glenoid labrum, which is very common. The SGHL is the superior glenohumeral ligament, and the CHL, the coracohumeral ligament, as well as the subscapularis, are thought to play a role in stabilizing the long head of the biceps. It really prevents medial subluxation of that long head of the biceps. I'll show you an anatomical study that we published that illustrates that. The long head of the biceps also acts as a humeral head depressor and a tension band, and it provides dynamic restraint and contributes to concavity compression of the glenohumeral joint. And historically, it was thought that maybe the biceps probably didn't play much of a role within the shoulder, but we now know, and it's very clear that through many biomechanical analyses, that the long head of the biceps has a very important role within the shoulder when it comes to stabilizing the glenohumeral joint. And in this picture that you can see here, it's an arthroscopic image. Number 5, that would be the long head of the biceps crossing the glenohumeral joint. This is an anatomical study that was performed evaluating the effect of the long head of the biceps on glenohumeral kinematics, just going deeper into what we just discussed. And they found that loading the long head of the biceps decreases the anterior to posterior translation as well as the superior to inferior translation of the humeral head in relation to the glenoid. And sequential loading of the biceps shifted the humeral rotation center more centered in the glenoid. So it helps center the humeral head within the glenoid. And so the long head of the biceps seems to act as a ligament at the extremes of rotation, limiting humeral head translation. So again, really helping to stabilize that humeral head and centralize it within the glenoid fossa. This is the anatomical study that we published with John Kelly and Brian Sennett out of Penn, looking at the comma tissue, which is really the coracohumeral ligament and the superior glenohumeral ligament. And this basically forms as a confluence with the cranial aspect of the subscapularis at its insertion on the lesser tuberosity. And this tissue, it's really called the comma sign of the comma tissue when you have a subscapularis tear. However, when we talk about the biceps, this helps to provide a medial border or sling to the biceps to prevent medial subluxation of that biceps. Now, positional portal placement, there's two main ways in which to do surgery within the shoulder arthroscopically. This is the beach chair position. This is the image that you're going to get in the beach chair position. You're going to see the glenoid on the right. You're going to see the humeral head on the left, and you're going to see the biceps traversing across the glenohumeral joint in the beach chair position. The lateral decubitus position, also an acceptable position to perform shoulder arthroscopy in. And in this position, you're just going to have the glenoid is going to be the floor, the humeral head is going to be the ceiling, and then you're going to have the biceps traversing from superior to inferior here across the arthroscopy screen and image. Now, portal placement is very important anytime you're performing shoulder arthroscopy, especially when you're working on the biceps as well. That asterisk, that's going to be the posterior portal where the arthroscope is introduced. I like to mark out my scapular spine as well as the posterolateral acromion. I do make a dot on the lateral acromion and follow my way around there. And I really like to define my posterolateral and anterolateral aspects of the acromion. Of course, follow the clavicle. You do want to have a sense of your spine and the posterior aspects of your clavicle. So you can utilize Navisor's portal if you're going to do a superior glenoid labrum repair. And I utilize my Navisor's portal for all of my superior glenoid labrum repairs. And of course, you're going to mark out the coracoid because when you create that anterior portal, you want to be entering just lateral to the coracoid. Now, the anterior portal for me, I perform an arthroscopic on lay biceps tenodesis. And so my anterior portal is going to be high and it's going to be medial. Why? Because I want my trajectory to be lateral, so I can have a good drilling trajectory within the lesser tuberosity of the humeral head. And so again, you're going to do spinal needle localization and localizing your trajectories while you're viewing within the shoulder joint arthroscopically. Now, techniques for the management of the biceps, the two general major categories is arthroscopic versus open. And you can do a biceps tenotomy, which is just cutting the attachment of the biceps to the superior glenoid labrum. That is an acceptable approach to managing superior glenoid labrum biceps pathology. I would say that I rarely ever do a tenotomy. I almost always do a biceps tenodesis. Now, in general, if you're a younger patient with a superior glenoid labrum tear, I am a biceps saver. Now, what do I mean by that? Well, as I just told you, the biceps plays a crucial role in the stability of the glenohumeral joint. And so if the patient has a superior glenoid labrum tear, I'm going to repair that superior glenoid labrum. We can talk about number of anchors that you're going to place. They're all going to be posterior to the biceps labral complex and biceps labral anchor, of course. But I save the biceps as much as possible because I want all of those biomechanical and kinematic effects of the biceps, as I just described, in the glenohumeral joint. Now, if it's a rotator cuff case, if the biceps is partially torn, if there is a significant superior glenoid labrum tear in an older patient, then I would consider performing a biceps tenodesis, and we'll get into some techniques for that. But for me, really, a tenotomy is not a part of my practice. And all of my biceps tenodesis are performed arthroscopically within the joint. And I'll show you a video of that coming up. But looking at arthroscopic tenodesis, this is the way that I perform it right here above the biceps groove within the joint. And you place your fixation, your anchor within the lesser tuberosity. Here's another option. You can do an arthroscopic tenodesis supra-pec below the groove. So this is below the biceps groove, but it is still supra-pec, and you can do this arthroscopically. And there's instrumentation there and cannulas that can be utilized to perform this. Another method that is widely performed that I do not perform personally, but is widely performed and completely acceptable is to perform an open subpectoral biceps tenodesis. And so you make a little mini incision. I'll show a video on this, about 2 to 3 centimeters incision just below the inferior margin of the pectoralis. And you can do an onlay or an inlay fixation method. You can use a screw. You can use a button. This one here, you can see they used a button. They went through bicortical. You can also use a unicornical intramedullary button, and they backed up their fixation here with a screw. So multiple ways in which you do it, but this is the open subpectoral tenodesis method. And so when looking, there's a lot of studies out there, but looking at biceps tenodesis versus tenotomy in general, and here's why this reason and this study and many others why I performed tenodesis as opposed to tenotomy for SLAP pathology. This is a randomized controlled trial looking at level 1 studies, and there's a systematic review. Again, most of the outcome scores, this one being the ASES score, the American Shoulder and Elbow Surgeon score, but many other outcome scores, they show similarities with outcomes with regards to tenotomy versus tenodesis. So from this standpoint, both are certainly acceptable ways to manage a patient who is a little bit older with SLAP pathology. Again, for myself, especially a younger patient, they're going to get a SLAP repair. But if you look at this chart, the tenotomy group had a significantly higher incidence of Popeye deformities as compared to the tenodesis group. So the tenotomy group is that second column. You can see that only one study is below 20% of Popeye deformity in the tenotomy group, as opposed to the tenodesis group. Only one study is 20% or higher. All the other studies are less than 10% for the Popeye deformity. And then I also have some cramping and anterior-based pain in that region of the biceps tendon with in the tenotomy patients as compared to the tenodesis. So again, I exclusively perform a tenodesis if I'm going to cut the biceps labral attachment. Tenotomy is really not part of my practice, but it is acceptable just knowing that these are some of the things that are different between a tenodesis and tenotomy. Now, considerations. Now, I think these are the things that we can consider. We don't have all these answers in the literature as of yet, but I think that One of the reasons why I'm a biceps saver and I repair the superior glenoid labrum whenever possible, especially in young, healthy, active patients, is because I don't think we fully understand the long-term functional outcomes if we perform tenodesis and tenotomy and we cut the attachment of the biceps labral complex. We may be developing concomitant pathology down the road because you have increased humeral translation in relation to the glenoid. Is that articular cartilage wear? Is that anterior glenoid labrum pathology, posterior glenoid labrum pathology? You might be developing osteoarthritis that then may lead to a conversion of total shoulder arthroplasty again in the future. So I don't think we have all of these answers. We know the biceps has a significant role in stability and concavity compression of the glenoid and centralization of the humeral head within the glenoid. And so these are the reasons why I try to save the biceps as much as possible. Here's a video looking at the surgical technique for a subpec, open subpec biceps tenodesis. You have a slight forward flexion, you have slight abduction and external rotation of the arm. You're going to go arthroscopically, sever the attachment of the biceps labral complex. Then you're going to make a 2 to 3 centimeter incision on the outside of the skin, again, on the inferior border of the pectoralis. You're going to go and find that biceps. Here they are making the incision here. And again, this is not my video. This is courtesy of a colleague. They're going to find the biceps tendon. You're going to release the biceps tendon, deliver that biceps tendon externally. There's multiple ways to do this now. You can whip stitch with whatever method that you prefer, and then use that and place that into a knotless anchor and dunk it in. You can place your anchor first, and then you could whip stitch through the biceps tendon, and then you can use a shuttle technique to then shuttle that biceps tendon in. It all depends on which fixation you're using. Again, inlay versus onlay fixation, a screw versus a button, intramedullary unicortical button versus a bicortical button. Sometimes if you use a bicortical button, you can drill a near tunnel and then place an interference screw as well as backup augmented fixation. You can see here they're placing the anchor first, and then they're going to whip stitch the biceps tendon, make sure it's appropriately tensioned, and then they're going to reduce that to the humerus. I'm just going to fast forward this here, and you can see they have the biceps tendon out here, whip stitching through here, and then they're going to reduce that down. And now you have your biceps tenodesis completed, and you're just going to tie your knots over the top of that. Now, this is the way that I prefer to perform mine. This, once again, is in the beach chair position. Arthroscopically, you're going to place an anterior portal that you can see there, as well as an anterior superolateral portal. So you have cannulas on both sides of the biceps tendon. Again, I'm viewing posteriorly here, so the humeral head is on my right, the glenoid is on the left. You can see in the distance there, and inferiorly, that's a subscapularis. And I've come through the rotator interval. I have speared the biceps tendon with a spinal needle. Then you place a PDS suture through the spinal needle. You come with a suture grasper through the anterior portal. And again, my anterior portal, I've already created high and medial so I can have an angle coming down for drilling. I use the grasper to grasp a piece of this PDS, but you don't want to pull it out. You want to pull the needle out first, because if you pull the PDS out with the needle in it, you could cut that PDS. So that's why the needle comes out first. Then you pull the PDS out of the anterior portal. Now you come in with a suture retriever device through that anterior superior lateral portal. You retrieve the PDS suture over the top of the biceps. So you're coming in here with suture retriever out of the anterior superior lateral portal, retrieving that PDS suture from that superior aspect of the biceps there where it was pierced. And now you have PDS that's gone through the biceps, and now it's out the anterior portal, it's out the anterior superlateral portal. Outside of the body right now, what's happening? There is a dilating knot that is being tied within the PDS, and then there's a loop that's being tied distal to that dilating knot. The free suture tape is going to be dunked within the loop, the open loop, and then this is going to be used as a shuttle. And you're going to see now as we shuttle, we're going to take the tape from the anterior portal, that anterior cannula, out this anterior superlateral portal and the anterior superlateral cannula. When we come through, we're going to have a dilating knot. That dilating knot is going to do exactly what it's intended to do. It's going to dilate a portion of that biceps tendon, allow room for the tape, the free suture tape, to pass. And you can see when the dilating knot comes in through here. There it is there. It's going to come through and dilate the biceps tendon, and then we're going to be able to pull our suture tape through from the anterior portal out the anterior superlateral cannula. Now, once that's performed, you're going to come in with a tape retriever because we're going to create a lasso loop technique. So we have the tape going through the biceps. Now we need it going around. The tape retriever comes through the anterior cannula. You come over the top of the biceps, grab the suture tape, deliver that suture tape, and you want to create a loop. This is the lasso loop. You come through the loop with your suture retriever, pull that tape tight, and then your assistant will deliver the other side of the tape through the anterosuperolateral portal. And again, we're already through the biceps when he speared it with the spinal needle. Now we're wrapping the tape around, creating a lasso loop technique. So your assistant is passing the suture tape to you from the anterosuperolateral portal, and you're going to take this through the anterior portal. So now you have that lasso loop. Again, outside the body right now, you're putting what I use is a knotless anchor. So your whatever knotless anchor of your choice, you can use a knotless anchor. That's being the sutures are being put in the knotless anchor right now. I'm going to come in with a drill guide, and again, I've already positioned my anterior portal appropriately, so then I can have a nice trajectory onto lesser tuberosity at the just adjacent to the insertion of the cranial aspect of the subscapularis on the lesser tuberosity. And so you're going to see the drill guide coming in here through the anterior portal as we find our exact spot for drilling. So it comes to the anterior portal. That is going to be malleted in, so it gets seated. So once you drill, you're not shifting and moving. It's going to get seated with a mallet. Then we're going to drill within this through the drill guide. Once we're done drilling, I then take my hand off the drill guide. You can see the egress of marrow elements here. I take my hand off the drill guide and I hold the cannula. I position the cannula, hold it firmly over the drill hole. My assistant then takes the drill out of the cannula, and I'm holding the cannula right over that drill hole. Why? Is so we can find it with our eyelet here. And you can see we're just going to dunk the eyelet right now. Now we don't mallet this anchor in yet because we're still tethered to the superior glenoid labrum. We dunk the eyelet in. My assistant holds the eyelet in. Now we come in with a radio frequency device for the anterior superior lateral portal. Then you want to cut and sever the attachment of the superior of the biceps to the superior glenoid labrum and the supraglenoid tubercle. And so, as you can see, when we do this, you're no longer tension. Now, because if you were to mallet that anchor in right now, you wouldn't get appropriate compression of the biceps because you're still tethered and you're tensioned. So now we're going to release that tension by releasing the biceps labral complex, and then we're going to mallet the anchor in. Now I seat the eyelet as well because we're already seated within the tunnel. We don't have to go find the tunnel right now. Sometimes if you're viewing from posterior, it can be challenging to get that view to find your tunnel appropriately and to find the trajectory appropriately. Right now, we don't need to find the tunnel or the trajectory appropriately. We already have the eyelet, as you can see, seated in there, and now we can just mallet right in. We can get perfect compression, appropriate compression of that biceps on the humeral head without worrying about being too tethered, because we've already cut the attachment of the biceps labral complex, and so now we're just malleting this in with whatever technique that you utilize for your knotless anchors, whichever one you're using. And then you can see the suture there. We come in with a cutter and we cut the suture in line and at the level of the humeral head. You see the cutter coming in there, cutting the suture, and now we bring the arm through a range of motion, and we see that the biceps is well fixed. This is an onlay technique to lesser tuberosity of the humeral head. This entire process takes less than 10 minutes, especially if you've done it a few times and you have an assistant who is familiar with your technique. But you can see their subscapularis is intact. This is an onlay technique. Arthroscopic biceps tenodesis adjacent to the cranial insertion of the subscapularis on the lesser tuberosity. So managing a biceps or rotator cuff tears, it's a very large topic, but one in which one of the aspects that I want to talk about is biceps rerouting and a tenodesis in situ for massive rotator cuff tears. We're also calling this a biologic SCR. We're utilizing the biceps as to help keep the humeral head depressed and inferior, so it doesn't superiorly migrate when you try to abduct the shoulder. Again, we're trying to keep the head down, and so we can utilize the biceps now in this manner. So a biomechanical study that looked at biceps rerouting as restoring glenohumeral stability. And what did they find? Well, they found that superior humeral translation was significantly decreased with the biceps rerouting and biceps rerouting with side-to-side repair. And so if you reroute the biceps and it was coming across the glenohumeral joint and fixed to the humeral head, this decreased superior humeral translation, very important for abduction of the shoulder and allowing for the appropriate glenohumeral kinematics of the shoulder. So they concluded that biceps rerouting biomechanically restored shoulder stability without over constraining when you have a large irreparable rotator cuff tear. These are different rerouting techniques. The ones I perform are really C and D. And so I prefer centralizing. If I have a massive irreparable rotator cuff tear or one that is just massive that I'm going to repair, I try to centralize the biceps. I keep it attached medially to the biceps labral complex and to the supraglenoid tubercle. I just centralize it, tenadese it, and then I repair my rotator cuff over the top. Now, there's been descriptions of repairing the infra or whatever rotator cuff tissue you have to the biceps. And these are multiple rerouting techniques, basically acting as a biologic SCR to prevent superior migration of that humeral head to allow for appropriate kinematics and biomechanics of that glenohumeral joint, especially with abduction. If you can see here, viewing posteriorly within the subacromial space, this is a large, massive rotator cuff tear involving the supraspinatus and infraspinatus tendons. Now you can see the biceps. I've already thrown my suture through the biceps with a lasso loop technique. You can see the articular margin there of the humeral head. And now I'm just centralizing the biceps with my probe and showing exactly how I want to fix this. Because when I repair the rotator cuff over the top, I'm going to place my medial row anchors. My anterior medial row is going to go anterior to the biceps. My posterior medial anchor is going to go posterior to the biceps. My biceps will be centralized. Again, I don't routinely fix my rotator cuff to my biceps tendon, but that is perfectly acceptable to do as well. You can also leave the biceps exactly anatomically where it is. I prefer to centralize the biceps, changing that force vector and really helping to hold that head down. So this is a knotless anchor. I've already done my lasso loop through the biceps tendon. I'm going to place the knotless anchor on the articular margin. You can see it's perfectly on the articular margin there. This is centralizing my biceps. I'm going to leave it attached at the biceps labral complex at the supraglenoid tubercle because I really want this to act as a humeral head depressor, and I want this to augment my massive rotator cuff repair that I'm going to perform over the top. This is augmented biomechanically. It also adds certainly more collagen for healing of this repair and really for massive rotator cuff tears. So as an example of a centralized biceps tenodesis for biologic SCR and augmentation of large, massive rotator cuff tears. Cut the sutures there, and you can see my anteromedial anchor for my rotator cuff repair is going to go anterior to the biceps, and you have plenty of room there anteriorly, as you can see. And then my posteromedial anchor is going to go posterior to the biceps, and this will be a double row repair over the top of the biceps. Now, moving forward, and what has been described as well as utilizing the biceps as a collagen scaffold. And so this is a study looking at autograft biceps using a scaffold to biologically augment large, massive rotator cuff tears. And so what do you do here? You take out a section of the proximal biceps. You're going to butterfly the biceps, sort of like as you would for a split thickness skin graft. And then you can see in D that final autograft longhand of the bicep scaffold there that's going to be used as augmentation for rotator cuff repairs. And in this study, what they find? They found that biologically active construct may help to improve the quality of healing and regeneration at the repair site of rotator cuff tears, especially those that are high risk for re-tears. So there's a lot of ways in which, as we move forward, we're utilizing the biceps for massive rotator cuff tears, both as biologic SCR and augmented fixation to help us biomechanically, as well as with added autograft tissue. And then methods like this, we're augmenting massive repairs with utilization of autograft tissue in the biceps. So final thoughts. know and respect the anatomy and biomechanics of any joint, in this particular case, the glenohumeral joint. Indications and outcomes for tendinosis and tenotomy, really know those and know why you're performing in certain circumstances and when it may be appropriate. You certainly want to understand various surgical techniques. Have a technique that you're familiar with and that you perform often and that you perform well, but you certainly better be aware of all of the various techniques that are out there. And then understand that there is really an evolving future of biceps utilization, of shoulder surgery, and how we're going to be addressing the biceps in superior glenoid labrum tears and now with massive rotator cuff tears. And I thank you for your time for this talk on the utilization of the biceps, clinical decision making, and modern surgical techniques. Thank you.